All right, we've got a nice little crowd here. We can all be good friends. It's a tiny crowd, but we'll take that. It's good. The last day of the conference is always hard. I'm Brian O'Sullivan. I'm a pediatric pulmonologist from Dartmouth Hitchcock Medical Center and the Geisel School of Medicine at Dartmouth. And I'm co-moderating along with Kirby Smith, who's from the University of Missouri. And I'm just going to start with a few introductory slides to get us kind of talking about charting the course and tackling all these challenges that we have ahead of us as we try to take care of our patients with cystic fibrosis and help them through the healthcare jungle, I guess I'd call it. So again, no disclosures of note. And I'm sure none of you can actually read this, but back in 2013, a group of us who were pretty concerned about the cost of Kalydeco when it first came out. And we published a commentary in JAMA about the price and would, in fact, society be able to bear all of this. And I know no one except perhaps in the very front row can even read the yellow highlighted part, but one thing we said was that the issue of drug pricing goes beyond a single orphan disease. It's a problem that will only intensify with advances in personalized medicine based on individual and disease-specific genetic information. Ivacaftor is just one example of the high price of niche medications. And we published that 12 years ago, and I just noted this summer that Reuters in May of 2025 said prices for new U.S. drugs doubled in 4 years as focus on rare diseases grows. So we were prescient 12 years ago, and unfortunately this is an issue not just for cystic fibrosis, obviously, but with the expensive drugs that we have for our patient population is something that we as care providers have to navigate, but our patients and families really have to navigate. So the drug manufacturers set the price, and that's often known as the launch price of the drug. So what they decide it should cost at the beginning, but then that launch price has to go through all the supply side people to finally get to our patients, the consumers who then have to use the drugs and have access to them. And costs are going up. And again, this is from 2025. The Reuters was from 2025. This was an NPR story about healthcare costs soaring. So this is an issue that's certainly been all over the news. In this report, they were talking about our employers being at fault, but I would say our employers are just stuck with all the costs that are going up, 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 and they are being passed on to our families, which is, again, another huge issue that our families have to deal with. And our patients. I'm a pediatrician, so I say families, but obviously the adult patients are trying to get through this morass on their own. And health insurers are denying more and more drug claims, despite some of the concern over the past year or two about prior authorizations and the troubles with that. In fact, the New York Times just in July published this story that showed this increase in drug denials by private plans over the past several years. So ongoing issues for our families and patients to deal with this, and I'm looking out at our pharmacy tech who has to deal with all of these issues, and these denials are a real concern for everybody involved. But that's okay, because it's actually really simple. This is a simple outline of how easy it is to get through all of this. There'll be a quiz at the end of the day for all of you to deal with this, okay, and work with this. It's a morass, it's a jungle, and getting through all of this is really difficult. So fortunately, we have a group of people who are going to help us chart this course and get us through. So we're going to start, and I apologize. I left Kate Sebring's name off of this. Kate and Colleen are from the Cystic Fibrosis Foundation. They are Compass Care managers who have been working with the CF community for the last 6 years. They'll be talking about the healthcare insurance complexities. Emma Dean, who's from Dartmouth College, will be talking about pharmacy benefit managers and how that all works. Teresa Albin, looking at some of the changes, and there have been a few changes over the past year, so looking at that as we go into open enrollment now. And then my co-moderator, Kirby Smith, will be talking about the role of social determinants of health. So a lot on our plate going forward. We are going to have a panel discussion at the end, so I would ask that you hold your questions for the end, and we'll have a panel discussion. So, Kate, I think you're going first. Is that right? Do I do the Colleen Walker one? And then you can either just do enter or you can use that, whichever you like.
Okay, perfect. Thank you. right. Hi, everyone. So my name is Katie. I am a case manager, as Brian mentioned, with Compass, and I have been with the foundation for over 7 years at this point. But this is my first NACFC, so I'm very thankful and happy to be here. So we will, both my colleague Colleen and I will go over the navigating the complexities of healthcare insurance for people with CF. There are no relationships to disclose. Okay, so for those who may not know a lot about Compass or those who may already know, just a reminder, Compass eligibility. So our services are available to individuals with CF as well as CRMS, including those who are pre and post-transplant, their families and caregivers, as well as providers. Compass is open to anyone. There's no insurance, income, citizenship status, or care center criteria. Compass is a free program to use, and it is confidential as well. So Compass primarily focuses on navigating people through the insurance system and helping them access medications, devices, and therapies identified in their treatment plan. So Compass does not provide direct financial assistance. However, what we can do in some instances is look for financial assistance resources for people in various areas. And this is because the CF Foundation's vital work in research and care, this has led to dramatic increases in life expectancy and quality of life for people with CF. So again, just the foundation's vital work in finding a cure for CF. All Compass recommendations or referrals are based on the individual's prescribed treatment plan, so we do not offer medical advice or tell people what plan to choose. And I'll talk a little bit more about what we do with that process of helping people with their insurance options. Compass primarily focuses on U.S.-based resources and treatment. We will, time to time, get some non-U.S. calls, so we will assist non-U.S. residents when possible, but we are pretty limited there. Right, so I am going to go over insurance options and what Compass does in helping people navigate that. So the main insurance types are going to be employer, marketplace, or private. So those both are commercial insurance. And then Medicare, available to those who are 65 or older, and then also who are on Social Security disability. And we look at original Medicare and Medicare Advantage plans. And then Medicaid and CHIP. This is a state program, so Medicaid and CHIP looks different in every state. So when we do get an individual calling from that state, we have to make sure that it would be an option for them. There, unfortunately, are some states that haven't expanded to adults, meaning there are people who age off of Medicaid because they no longer are eligible due to their age. So open enrollment, we have actually already dived in, starting with Medicare. Medicare had started on October 15th. Open enrollment is definitely Compass's busiest time. And so we, as I mentioned, Medicare had already started. So starting to get some calls and working cases there. Marketplace and private typically starts November 1st, so gearing up very soon for that. And then employer plans vary, so it typically happens generally at this time of year. We do, however, get random months throughout the year where an employer is going through their open enrollment, so just kind of depends there. And just want to point out one more thing too. So for those who aren't aware, open enrollment is when, so you want to make a change or, make sure that you are renewing your current coverage, making sure that, if you do stick with that same plan, if it's available, if you're eligible for it, want to make sure that there's no changes for the next year. So that is definitely important to make sure of that. Generally, you cannot make changes to your insurance outside of open enrollment unless a qualifying life event were to happen, such as moving, getting married, a birth or death in the family, getting a divorce, people aging off of their parents when they turn 26, turning 65, becoming Medicare eligible. I think those are most of those. Okay, so considerations for choosing a health plan. So what is the time frame to make a choice? So again, just as I mentioned, typically either during open enrollment, which is at the end of the year, and then that coverage would begin January 1st. For the most part, again, employer plans can be a little up in the air sometimes, but generally open enrollment between, roughly October to December, January 1st for that start date, or a special enrollment period. So if someone does have a qualifying life event occur, they typically are granted 60 days for a special enrollment period to get into a new plan. Coverage for medical needs. So when we get calls from people needing assistance with looking at their insurance options, we collect a bunch of their information. We get a full list of their providers, the CF Care Center that they go to, and also any doctors that they see for that matter. It doesn't necessarily have to be CF related. We know that a lot of patients, see a variety of care teams and providers. So full list of doctors, full list of their medications, and then any other priorities that they might have. So that could include mental health, if they have had a transplant, frequency of hospitalizations, if they use any durable medical equipment. We just really want to make sure that we're collecting all of that information to check the coverage with the plan options that we're looking at for them. And then the built-in costs. So we, as case managers, we are obviously trying to find the best plan option that's going to meet coverage needs for them. But we also keep in mind the costs that they're going to have to encounter throughout the whole year. This would be the monthly premium cost, deductibles, medication copays, especially those specialty medication copays for, medications like modulators. And then also paying attention if that plan has an accumulator or maximizer program. Colleen will go a little bit more into what those mean. And then what assistance is available. So typically while we are looking at insurance plan options, but then afterwards as well, after we kind of get them set up with that, we connect them to any copay assistance programs through the manufacturer for their medications, if they're not enrolled in anything like that, or maybe they weren't eligible, but now they are. So we just make sure we cover our bases with them to point them to those programs. If there's something, if we, we obviously try to find the best plan possible, but if there's something that's not covered, we try to find some sort of resource or, assistance there with not covered costs. Oh, I'm so sorry. I think I meant to say nonprofit copay cards, along with manufacturer copay cards. So nonprofit copay assistance, an example would be like HealthWell Foundation. And then also some plans have a built-in HSA or HRA fund. So that's something to take into consideration as well. And then a big reminder in red. So it is important to review plan details every year, even if it appears on the surface that nothing has changed. So for instance, if someone is looking at, their specific plan name and they happen to see, oh, okay, it's offered on the marketplace, that same plan next year, we don't want to make any assumptions that it's going to be the exact same as it was this current year. We really want to look through everything and check those doctors, medications, other priorities, just to be safe, because I'm sure a lot of people know a lot of things can change with insurance very quickly, and not always it's not always openly communicated from the payer. So here's what to expect when an individual with CF or a parent, grandparent, family member of someone with CF reaches out to Compass and they would like some assistance with navigating their insurance options. So we are a team of case managers. So whoever gets that initial call, we do an intake. We collect minimum information required and then any applicable documents. So that an example with that would be, let's say someone calls and they got a new job, or it's their open enrollment with their job. We don't have access to what those documents are with that employer coverage, so we'd want to make sure, as we're creating a case, to have someone help out, that we are communicating that to them, that we need specific documents for us to really look over that coverage. And then next step would be, so if we get a call and if it's something that's going to take a little bit more work to do, research, we typically will create the case and then it will be assigned to one of us case managers to work on. And so we typically go on a first come, first served basis. We also know that sometimes people need immediate assistance. They, either find out that they have a very short window for their open enrollment. They need help with that decision right away. They can't wait a few days. So we will prioritize those cases, make them a rush case, which basically means either that person, if they're able to try to navigate that on that first call, we can sometimes do that, or we will get it assigned and very, very quickly. So someone will reach back out to them as soon as possible. And then, so once a case manager gets a new case, they will make an introduction call to the person who reached out, and we will confirm that all the information is correct, and then retrieve any missing information that maybe was missed on that first call, or, maybe someone said, oh, I forgot to add this doctor, or I forgot to add this medication. So we're just, again, making sure that we have as much as we can. And then we just set the expectations for moving forward. So we let them know that we're going to be, researching the plan options. And again, it just kind of depends if, which category it is, if it's employer, marketplace. But I'll give an example. If we're looking at creating a marketplace plan comparison, we'll let them know that we will research all those plans available in their zip code, letting them know that we will check coverage and costs as we look through those plans. And then going into evaluation. But again, I'm just saying what we would tell them over the phone, just so they know what we're doing and when they know when to hear back from someone. But yes, then going into evaluation. So again, we evaluate those plans. We can, depending on which type of insurance we're looking at, we can put together a plan comparison, narrowing down and again, it kind of depends, but if we're using the marketplace plan comparison, sometimes people will have like 100+ plans to choose from on there. So we really try to narrow it down extremely. We can narrow it down in that instance to about 3 plans. And so we can't tell them, go with this plan, this one's the best. But again, hopefully helping them, again, narrowing it down. And then when we do talk with them after we do all this work on our own, we will put together a plan comparison, put together a summary, and we'll go over the pros and cons of why we chose these plans, the similarities and differences, things like that, just so that they hopefully feel a little bit more confident in choosing which one they think will be the best for them, either on an individual basis or for their family. And then, so after we get back in touch with them and, we usually, if possible, email that information over. But again, we talk with them over the phone. We go over kind of what we put together for them in that format. And then the conclusion here would really just be, after we explain what we, found out and put together for them, just addressing any outstanding questions and discussing the next steps. Which brings me to this. So help doesn't stop at the plan comparison. So we just, as we're evaluating those options, we want to make sure that after we give them the information, they feel confident. They don't in which direction they might want to go. We also want to set them up for success by referring them to cost-saving resources, making sure if we can find in-network pharmacies that's going to work with the new plan that they are thinking of going with. And then also just having that conversation of letting them know that, hey, since this, if it's a new plan that they're getting set up with, that for a lot of those medications, especially the specialty ones, just to expect a prior authorization will be required. So that can take a little bit of time. So them just knowing that, kind of gearing up so that they can, reach out to their pharmacy, reach out to their care center, letting them know which plan, that they'll be on a new plan and which one, things like that. And then, anticipating challenges. So I would say we want to try to, again, we're setting them up for success. We're trying to give them the big picture of what to expect, really giving them guidance on how to spot and handle issues if they arise. And we also just really want to drive home the fact that they can reach out to us if the plan starts, and then if something doesn't seem right when they go to fill a medication or they get a bill in the mail and they have questions, we really try to, let them know that, hey, it doesn't stop here. If something weird happens, it just doesn't seem right, reach out to Compass and we will look into it. And if we have to reach out to the insurance and figure out what's going on. So we really just want to show people that we are here after, we're not just giving them the plan comparison and saying good luck. So we really just want to continue that ongoing support. Okay, so important steps when transitioning to new insurance. So first, enroll in the new plan as directed. Pay the monthly premium to activate the coverage. So typically, if someone is enrolling in an employer plan, this is usually done via payroll deduction. So typically, they don't have to do too much there on their own, except definitely make sure they're enrolled. For Marketplace or Medicare plans, patients set up payment directly with the plan. So they can either do this by creating an account online or calling the plan directly and just making sure that's set up. And then reminding patients to watch for payment deadlines. And again, we're talking about the monthly premium. So just, it's really important that they know when the premium is going to be taken out. Missing the first payment can delay or even cancel coverage. So that's super important to just know how that is set up. And then, as I just mentioned previously, so, notifying providers, pharmacies, also people who are enrolled in copay assistance programs, letting them know that they have this new plan. It also is good to just let them know, even if they are keeping the same plan, but just still making sure that they're letting those copay assistance programs know regardless. And then, yes, as also I mentioned, providers may need to submit prior authorizations as well as possibly resubmitting prescriptions under the new plan. So just we try to let people know that, so there's not a gap with, them trying to fill their medication, just trying to get them to set things up, right when the plan starts and a little bit even before, just knowing what they need to do there. And then understanding referral requirements. So some plans require a primary care physician to send a referral to see a specialist. And so, a lot of these doctors, CF, are specialists. So, and that could, for example, could be like an HMO plan. So just making sure that, and that is usually listed on the summary of benefits for the plan. It will show on there, is a referral required to see a specialist? It will say yes or no. So just paying attention to that. And then patients must first visit their in-network primary care provider to obtain one. So just basically that means just making sure that your current primary care provider is in network with the new plan for them to send that referral. And then review pharmacy requirements. So some plans may require patients to switch to preferred or specialty pharmacies. This is a big one for specialty medications such as modulators to those who take them. Of course, there's other specialty medications as well, just an example. But yes, just making sure that they know if they need to fill at one of those pharmacies, and if so, which one. And then mandate that maintenance medications be filled via mail order services to reduce costs. So sometimes there's that requirement under the plan as well. And I'm going to kick it over to Colleen to go over the second half. Thank you.
All right, thank you, Katie. So we'll kind of go over some challenges that we're seeing, how we're mitigating them here on our team. Hope you guys can learn something new in this next session. So we shall see. So some things that we want to watch out for. Starting with self-funded versus fully insured. If this is the first time you guys are hearing of this term, that's fine. Main takeaway here, fully funded employer plans, that is, are subject to Affordable Care Act and state law. So we have to cover, what the ACA requires. Self-funded, you don't. The plans can kind of do what they would like. They have more flexibility, essentially. So main takeaway there. Additionally, cost relief programs. This is your accumulator, maximizer, alternative funding programs. If it sounds too good to be true, it probably is. They make these programs very rosy. So again, too good to be true, probably is. Changes in status of assistance programs. This is HealthWell, Patient Advocate Foundation, the Assistance Fund, that are all three closed right now due to running out of funds. Would like to say that for any of your patients that are going to be needing these funds, there is a way to sign up for fund alerts once the funds reopen. Would suggest any of your patients doing that. And then third-party program stability and changes just in general as well. Deductible structure, what services are subject to the deductible? Is there a flat copay for specialist before or after meeting the deductible? Diagnostic testing, things of that nature. As well as employer plans, again, we're talking, is there an individual deductible, which we call embedded? Or if you're on a family plan, is there just a family deductible or aggregate? And how does this impact us? To dive a little bit deeper onto the fully funded versus self-funded, again, if this is new terminology for you, this is about the inner workings of these plans and how it affects the employer. Fully funded, the employer takes the monthly premiums from the employers and sends it to the insurance plan. The insurance plan then takes that money and pays the claims from there. In contrast, self-funded plans, the employer keeps that money. and then they pay the claims from there. That way they have more flexibility to cover, to pay claims as they see fit. So how does this maybe affect when treatment is denied? It varies. This is a relatively, it's not for sure every single time this is going to be the process, but fully funded, there's a better process for denials. If we're talking marketplace, we can take these up all the way to the Department of Insurance for the state. For example, my home state, Illinois, if they are on a marketplace plan, Pulmozyme is denied, it's not on the formulary, cool, whatever. Care team submits an appeal, we can take that all the way up, like I said, to Department of Insurance. Self-funded, not really an option. And really the biggest thing with this, again, that I want to hit on, since the employer has more flexibility, sometimes we're talking about patients and families bringing this issue up to their employers, which if it is their decision whether they want to bring up their CF to their employers. So this opens up a whole slew of issues. They may not feel comfortable talking to their employer about their high-cost medication or their rare disease. So it just brings in a lot of additional considerations that are concerning. And then worst comes to worst, we got to find a different plan. Obviously, we're in open enrollment. Let's try and see if there is another better option that you would have better access to your medications, providers, all of that. Cost relief programs, talked a little bit about that and what we're looking for here. Again, if these are new terms for you, accumulators essentially just mean that the plan is not going to count manufacturer copay assistance towards the deductible and out-of-pocket maximum. These are very pervasive. We see this very, very, very often. It will continue to increase, so keep an eye out for that. Maximizers are also being increasingly popular because they save plans buku bucks. Copay maximizers essentially take all of the available copay assistance through a manufacturer and try and maximize that. So for example, again, we all talk about modulators. Vertex provides $20,000 a year with a annual or per month max of $3,500. So these plans will take the $3,500 from Vertex per month, cover the rest. With this, they will run out of Vertex copay assistance, typically like a half fill in June, but they should continue having a $0 cost throughout the year. That copay assistance is not going to count towards that deductible and out-of-pocket maximum still. So all maximizers have accumulators, but not all accumulators have maximizers. So that's kind of how we look at that. And then the ultimate beast is alternate funding programs. And so I really want you guys to look at some of those examples there. If you guys see any of those, please call us. These are a disaster. Somehow I've kind of fallen into this little bucket that this is often what the cases that I get, so lucky me. So these third-party programs, they partner up with the employers that don't want to cover high-cost specialty medications like modulators, and they try and get you on manufacturer copay assist or manufacturer free drug. Well, manufacturers have caught on to this and will not allow enrollment in their free drug program. So now their plan isn't paying for it, the drug manufacturer isn't paying for it, and the patients are just in the middle. Like, I just need my medication. Come on, like someone, please. So bad news bears. We definitely see a lot of people going without meds in this process. So please, if you guys see any of these terms, give us a call. Here is some data of kind of some different things that we're seeing, 2022, 2023, 2024. We can see in the insurance comparisons, this is steadily increasing, as people are getting kicked off Medicaid after the public health emergency from COVID. We are going to continue seeing that. We like to say open enrollment is now all year long. Lots of people getting new jobs, losing jobs, moving, getting married, getting divorced, all the things. Coverage and reimbursement is, kind of hit or miss, but definitely increasing as the healthcare landscape gets a little bit more jungle-like, because I like that word. I'm going to use that. And then we can see health-related social needs. This is rent, utilities, mortgage, your regular monthly bills is also increasing. This general trend, increasing. Here's some 2025 current stuff. This is a big slide, know that. If we want to just focus in on that, like circle kind of our different pieces of the pie here. Starting with accumulator and maximizer, just like I talked about a couple slides ago, and how we mitigate that. We're talking about strategizing order of medications. Do we fill a modulator first? Do we fill pulmozyme or maybe an enzyme first? So we've gotten very creative on how to get those to work. Otherwise, durable medical coverage, these are your vests, if anyone's on a G tube, J tube, some of that stuff, oxygen, things of that nature, which can be challenging. Administrative billing issues, you guys see this probably every single day. Payer pharmacy engagement, if they disagree, especially like any sort of coordination of benefits, if people have multiple plans, we could see that issue. And then vitamins and supplements, which is obviously, I'll go into in a later slide, definitely something that you guys are all probably thinking about. And then just here quickly, 90% of people experiencing access issues this year did not reach out to us during open enrollment. And just like Katie said, a lot of those people most likely said, well, my plan isn't changing. The plan name hasn't changed. I'm good. So we really want to make sure that people are reaching out to us regardless. It's always good to have a second pair of eyes. It is not anything against them and their ability to review plans, just good to kind of get a second pair of eyes. All right, vitamins and supplements. Obviously, very aware of the situation here. So here's how our team is approaching this. We are first kind of looking at their insurance coverage. The main people who are experiencing issues right now is people on Medicaid. Medicaid doesn't always have MVW, DECAs, things like that on the formulary. So, and they can't pay. They're on a very low income. They can't pay for these things out of pocket. So what we're doing is we want to investigate the insurance first. For people on Medicare as well, if you're on a Medicare Advantage plan, there is typically a quarterly over-the-counter stipend, though these are typically sometimes I've seen as low as $30 a quarter. Well, for people with CF, that's not going to work. So we need to find something else. And then, so our payer team who are in the audience and up here as well, we are actively engaging with 6 states, their Medicaid programs to get MVW, DECAs on the formulary. This is part of their plan. The plan is, paying for modulators, paying for enzymes. They got to pay for the vitamins and supplements. That's a part of their medical care. So if any of you guys are actually actively experiencing issues with access to vitamins and supplements, whether you're writing a letter of medical necessity and it continues being denied, please email that to me. And we that is how it started with these other 6 states that we're actively engaging with. We've written letters in conjunction with some of the care teams to advocate for Medicaids to add the vitamins and supplements to the formulary. As well, the manufacturer assistance programs, this is really only commercial insurance. It's a good resource to have, though, again, the people that are mainly experiencing issues are going to be the people on Medicaid. State-based programs, which is really something that our team is really trying to hone in on, as some states, not all states, have a children with special health care needs, or sometimes there is an adult program as well that can help with some of the vitamins and supplements cost. And then any financial assistance resources, if we have exhausted all of these things, there is nothing for vitamins and supplements, we're going to look at their other monthly bills. What can we research to find help for rent, mortgage, utilities, any of those other monthly bills that we can try and help look for assistance for? Does not like my finger. Okay. There we go. So we've talked kind of about all of the issues that we're seeing, and this is additionally how our team is mitigating that. So our policy and advocacy department as a whole, we are identifying trends, obviously the trend, vitamins and supplements, maximizers, accumulators, all of the jungle. And we're prioritizing based on, the trends and the current landscape that we are experiencing. And then we're engaging with legislators, payers, and other relevant parties, Department of Labor, HHS, things of that nature, CMS, all of those big players. If you have questions or access issues, reach out to us, reach out to our policy folks. There's their contact information at the bottom there. We all try and really work together to make sure that everyone has access to equitable coverage. I'll leave that up for a second. There you go. All right. And then additionally, how we're working together with you guys as care teams. If you guys talk to, refer someone to us, there may be a lapse of coverage. You say, hey, but they're out of meds too, so we need a plan like now. We're going to talk about that, providing up to 3 plans typically to compare. So it's a full circle that we really rely on each other to make sure that everyone is on the same page and that everyone kind of feels good about their plan forward. Here's some resources. Navigating CF, if you guys were in the social worker networking yesterday, so this slide is going to look very familiar. This was from some of our policy team that put together some videos talking about navigating CF in the insurance world. CF resources for clinicians on my.cff.org, as well on the NACFC app. If you scroll down just a little bit, there is a CFF resource board. Click that. You can scroll down to Compass as well. There is a maximizing vitamins and supplements resources on there as well. So star it, favorite it, screenshot, whatever. But highly suggest that. QR codes, because everyone loves QR codes. More about CF Foundation programs as well. I'll leave that up for a second. And then contacting Compass. These are the 3 ways to contact us. We had certainly been listening to care teams as well, as far as any sort of like consent issues as well. If you want to follow up on someone that reached out to us, and you're like, hey, how did that work out? What happened? We have refined our consent process so that we just consent pretty typically. So we want to make sure that we're all working together so that it shouldn't be as much of an issue as you may have experienced previously. Again, you guys know some of these patients better than we do. You guys see them every quarter for years and years and years. So we'll follow your lead as far as how it works best for them to contact us. What could work well is if you guys call us with the patient family, whether you guys are in clinic or they're on the phone, and we can gather all that information while we're on the phone. Otherwise, if they prefer email, which I know people do, you guys can have them CC'd and then email the Compass email, and we can take them from there. And then there is just an online service request. It is only available for people with CF, caregivers, parents, and legal guardians. It is there, as if phone or email doesn't work, but phone and email is going to be preferred. Thank you.
Awesome. Thank you so much, Colleen and Katie. I do want to interject, though, because I got the email notification, because I get fund alerts for my patients. There is a Patient Advocate Foundation copay relief fund currently open for cystic fibrosis for up to $5,000 per year for assistance with prescription medications. So that just opened on Wednesday. So I'm next going to introduce Teresa. No, Emma, I'm so sorry. Emma, I'm out of order. Emma is an assistant professor at Dartmouth Institute for Health Policy and Clinical Practice. She is a health economist whose research focuses largely on pharmaceutical industry, with particular interest in the study of high-cost specialty medications. Her research covers topics such as drug price negotiations and payments, pharmaceutical price controls, pool purchasing of pharmaceuticals, and price transparency. Additionally, she studies the relationship between poverty and health, with particular focus on access to medication. for underserved populations. She earned her PhD in managerial science and applied economics from the Wharton School of University of Pennsylvania. Oh, I didn't mix up. I just clicked on it. There you go.
Thank you. And thank you for having me here. I will say, not ACF expert. I am a health economist, but I am here, as I said, because I study high-cost prescription drugs and have the same passion as everyone in this room, which is increasing affordability and access for patients. So with that, going to talk to you about something a lot of people haven't heard of, which is PBMs. They're pharmacy benefit managers or pharmaceutical benefit managers, and as well as the rest of the supply chain, going to actually cover some of the same topics we just heard about and no relationships to disclose. All right, so as mentioned, I say specialty drugs. This is where the CF medications would lie. These are generally high-cost medications to treat oftentimes rare, complex, or chronic health conditions. And most people, when they think about drugs, they don't think about these medications because most Americans don't take them. They are less than 2% of scripts in the US, but they're over 50% of costs. In fact, I just saw some data from New Hampshire that they're over 60% of the cost of drugs in the state of New Hampshire. And they're the large majority of our spending growth. So this is not just relevant to CF, this is a much broader issue in the US society, whereas this is driving almost all of the increase in spend that we see on pharmaceuticals. But again, less than 2% of scripts. So we do care, consumers here, of course, are patients, the person taking the drug. And you, of course, on the other side have the manufacturer. And in econ, we call this the demand side and the supply side. But as Brian showed you earlier, the supply side is much broader when we're thinking about access to medications. We've got, of course, a physician who's prescribing the drug. They're working in an office or hospital setting. You have pharmacies, and in this case, it's often a specialty pharmacy, which is generally a mail order pharmacy. Sometimes they're in person. You have the PBMs, who are the purpose of today, and I'll talk about in a second, and of course, insurers. And all of these are working together. And this is good and bad, because of course, it's easy if we're thinking, well, we need to increase access for patients to just blame the manufacturer for high prices. But the drug does not flow directly from the drug manufacturer to the patient. You saw something earlier. This is a more simplified version of the supply chain. And I put the simplified one up because it's hard to read when I put the full version up, even on a large screen. And so the group we're talking about in particular today is kind of in the middle here. I won't try to use this clicker, but it's that pharmacy benefit manager. They're an intermediary that sits between the payer, which is the insurer, and the manufacturer. Right. And PBMs are pretty secretive, so they do a lot of this negotiation. I'll talk more about what they do in a second. And to give you an idea of how secretive they are, I said I simplified this. There are now two intermediaries between the intermediaries. One of these is these GPOs. These are they call them group purchasing organizations or rebate compilers. They have offshored these, put them in Switzerland and Ireland, which not only, of course, comes with tax benefits, but also makes this even more secretive, to the point where I've heard federal government has tried to now subpoena them to get more information, and they've just been able to ignore that subpoena. Right? So when we're talking about secretive and this is hard to understand, I think about this over 40 hours a week. This is all I do, and I don't really understand a lot of this. It's very opaque. And so if you're getting frustrated not understanding the system, just know that you're really not alone. All right, so what are PBMs? These are intermediaries, again, that sit between the manufacturer and the insurance company. There's three main PBMs in the market. You've probably heard of them. You may even have received mail from them. CVS Caremark, Express Scripts, and OptumRx. What PBMs do is they negotiate rebates and lower prices with manufacturers. So they essentially pool a bunch of insurers together to increase, have a bigger negotiating pool with the goal of lowering prices. They also manage payment, oftentimes for these drugs, and they design formularies. So this is what drugs are covered and at what cost sharing level for patients. So they do a lot here, and there's a lot of good things they do. But they're still controversial. And the reason they're very controversial is because those rebates that they negotiate are secret. They are trade secret. No one knows what they are. And so it's considered black box pricing. So we hear about prices all the time and how prices are. No one knows actual negotiated net prices in the US. And when I say no one, I am including the federal government. No one knows this landscape, right? We know the list price, we can kind of back out some estimates of what's actually being paid, but no one really knows. What's also controversial is that these PBMs, they keep a percentage of the rebates that they negotiate. So what does this encourage? Well, of course, they're also setting the formulary. They're saying, what am I going to cover? And at what rate, at what coinsurance am I going to cover you? I'm going to prefer your competitor over another drug, right? What this incentivizes is for manufacturers to set very, very high list prices and then offer deep rebates to the PBM. Now, one of the problems with this is that patients' coinsurance rate, which is a percentage of the drug that they have to pay, is generally based on that list price. Because again, remember that net price, that rebate price is secret. Right? And so this is something that does actively harm patients, especially those who have to pay coinsurance. And for most specialty drugs, that's how they're covered. They're covered with generally 20 or even up to 40% coinsurance rates that the patient has to pay out of pocket. And again, because there's lack of transparency, there's no public, disclosure of these rebates, we just generally do not know net prices. So I just told you we don't know net prices. I'm going to show you an estimation of net prices. This comes from firm 10K filings and total sales. It's not perfect. You can think about it as maybe an average price here, negotiated price. And this is insulin. So has anyone in this room heard, insulin prices have been rising out of control? Right. So if you look at that top line there, that is the gross price, the list price. That has been growing out of control. Right, 16% annual growth year on year. If you're paying coinsurance, your coinsurance has doubled in a short time frame. Look at that net price, that was 2%. That is actually growing slower than inflation in that same time. That is the negotiated price. And you see insulins are competitive. You see exactly what I said was incentivized. The list price is growing. They're offering deeper rebates to the PBMs and net price is not. So this is a good example. You've probably heard, I think it was Eli Lilly said, we are lowering our price to $35. No government forced us to do it. Yet they were already charging $35. It was just this secretive net price, right? So that was kind of what happened there. They didn't actually lower effective price. Another thing that's important here is that if you just look at list price, which again is that top darker line, you might think the competition doesn't matter. And in some spaces, I will be clear, it does not. Cancer is a good example, where if you see more competitors on the market, it doesn't necessarily lower prices. But in a lot of cases, it does. So this right here is for hepatitis C. And this first increase you see, that's Sovaldi. That was this first really innovative hep C treatment. And you can see that there was basically no rebate there because there was no competitor. The net price and the list price were essentially the same. What you see is over time, more competitors entered, and you see this net price dropped. Now, of course, the patient might not see this if they're paying a coinsurance, but the system sees it, right? We do see this decrease in price. So PBMs do show effectiveness at negotiating these lower list net prices, but of course, we don't see this and we don't see how this system works. All right, so we just heard about this, and I'm glad you brought this up, these maximizers and accumulator programs, because I've been thinking a lot about these as well, and they're not just relevant to CF, but I think they are particularly important with CF, partially because of patient copay assistance programs and how they're designed. And so what happens again in these accumulator programs and maximizer programs you just heard about is in accumulator programs, your copay assistance does not count towards your deductible or out-of-pocket maximizers. These maximizers work in similar ways where oftentimes it's kind of spread over the year and again does not count towards your deductible or out-of-pocket. So again, if you're a patient, one of these purposes of this copay assistance is to not have you have to pay such a high amount out of pocket, especially oftentimes all those costs come at the beginning of the year for patients before they hit their out-of-pocket maximum and before they hit their deductible payment. These kind of prevent that from assisting patients in that way. They still have to hit their deductible. They still have to hit their out-of-pocket maximum. And I do want to mention in general, another concern with copay assistance that is relevant here is that it's not available for off-label use. So if you have a patient who could benefit from a drug, but they're receiving it off-label, it's not officially FDA approved, they're generally not allowed to get copay assistance from the manufacturer. And here I put a little we won't go through this, and if your eyes glazing over here, just like it was earlier, again, super complicated. Want to mention though, these are kind of how these programs work, right? There's a lot of steps. If you're trying to navigate this as a normal person, it can be impossible, right? And so this is a concern. I agree it's overly complex. The fact that you're seeing it with patients is concerning. And I had actually specifically included this alternative funding program, which I'm very concerned about. This is something now where they're actually carving out specialty drugs entirely from coverage and then trying to cover them in other ways. And as you said, manufacturers have caught on. And so they're changing so rapidly that I've been going down a rabbit hole trying to learn about these, but they change so quickly that you can't just say what they do. In 3 months, they're doing something different. One of the things they're doing now is they're doing individual importation from other countries. The problem with that is that oftentimes you don't know where you're getting your drug from. Oftentimes the label is not in English, right? So they'll get it in like an acrylic writing and people will have, well, what am I supposed to do? And so there's a lot of concerns, I think, and we need to be paying attention policy-wise when we're talking about high-cost drugs to what's going on here. But again, really hard because they've been changing so rapidly. So I wanted to mention some regulatory things, and I think you've already talked about some of them. Some states do actually ban accumulators for state-regulated plans. So they say, you can't do this. This is unfair to the patient. It's just, these are designed to support patients who are trying to afford these high-cost medications, and now you're kind of taking that benefit away. However, as you mentioned, I call them self-insured plans, but this would be, they're generally not subject to state regulation, right? So self-insured employers do not have to follow some of these state regulations. This is 60% of workers in the US work for a self-insured employer. So I've seen all sorts of things. I've seen specialty drugs, again, completely excluded from out-of-pocket maximum limits on these state-regulated plans. Generally, I'm all about states can do everything, can't leave it to the federal government. If you're going after some of these insurance things, there do have to be some federal laws if you want to capture all commercially insured patients. There is a national reform pending. I haven't seen any updates on it. I would be interested to hear on your end. So really quick, want to end by talking about how all this affects patients, which is, I think, what everyone in this room is really cares about. So the first thing is most patients who are commercially insured do have a deductible. This is the amount you have to pay before the insurance kicks in. On average, that's about $1,500 or over $1,700 or $1,800 per patient. Adds up if you have a family, right, pretty quickly. About 2/3 of patients will face an out-of-pocket maximum above $3,000. So now we have our deductible and our out-of-pocket maximum. You're hitting $5,000, oftentimes due, again, in that first month of the year. Even if you're pretty wealthy, that's a high out-of-pocket cost to have to save, right? And increasingly, and I've heard this kind of from clinicians, they said, well, I can get access to medication for my patient. I'm having a really hard time getting them to come in. And so I want to mention that another trend that I'm kind of concerned about is that patients are increasingly paying co-insurance versus a copay for a specialist visit. So a copay is just a general like $25 or $50 you have to pay to go in. Co-insurance is a percentage of that total visit cost. It's oftentimes 20 or 40%. That actually makes it much more expensive for patients to actually go in and see that specialist. Also concerning is this is particularly happening amongst large employers who cover more patients. So I do want to kind of mention this. And I kind of end this way. My mom takes one of these high-cost specialty medications, not for CF, and she was seeing her copays go up and what she was owed, and she asked me about it, and I started to explain it to her, and I guess I kept using the word system. Oh, well, this saves the system costs. This saves the system money. She's getting really frustrated with me, and she goes, but Emma, I'm part of the system. And she's totally right. And I think one of my concerns is that these patients who are taking these high-cost medications are kind of being left out of these things that are being put in place to lower costs for employers, right? And they do need to lower costs, right? We understand there's this tension. Just want to make sure that patients are really included in those solutions. And I'll save questions for the end, but thank you.
All right, thanks, Emma. Up next, we have Teresa Albin. She is the Director of Federal Policy and Legal Advocacy at the Cystic Fibrosis Foundation, where she leads the foundation's federal policy priorities related to patient access and oversees the development and execution of its federal regulatory strategy. A highly effective health policy professional, Teresa brings extensive experience in regulatory and legislative analysis, federal and state level policy making, and navigating cross-cutting issues impacting agencies such as HHS, DOL, FTC. She holds a Juris Doctorate and Master of Public Health with concentration in health management and policy from St. Louis University and a Bachelor of Arts from the George Washington University.
Well, this has been a really fun chat so far. And to keep that trend, we're going to talk about health insurance laws and updates that have happened this year. So no disclosures to provide. Here's a quick agenda to see where we're going to walk through. My colleagues have already done an amazing job talking about what, health insurance looks like, but I'm going to do a light touch on that as well, just to talk about what some of the regulator opportunities are, then talk through some of the policy trends, new laws and regulations that we're seeing, and then what we anticipate in the next couple years. So to start off, let's look at what this means for people with CF, right? So 60% of people with CF are on a private insurance plan. 50% are of young adults are on their parents' private, most likely private insurance plan. 13% of young adults are on Medicare due to their access through disability, and around 36% of all people with CF are on Medicaid. And this is from our patient registry from last year. So as my colleagues mentioned, there's three real big buckets of what insurance looks like. We have private insurance, which can be employer-sponsored, direct purchasing, which is those ACA plans, but also there's non-compliant plans. And then there's these other group health options that sort of function outside of the insurance marketplace, and they function in their own rules in many ways. And then we have Medicare, which can be traditional Medicare Part D and Medicare Advantage, which functions like a commercial insurance plan. And then we have Medicaid, which is that federal state program. So again, just to reiterate, these self-insured plans, these employer plans that everybody has been talking about as being particularly bad actors, those only have federal oversight. Whereas Medicaid, fully insured plans, ACA marketplace, non-compliant plans, there's a federal state component to this so that the federal government sets that floor and states have additional oversight that they can do and levers that they can pull. So what are some of the policy trends that we are seeing? We've talked a lot about what drug policy looks like, but that unfortunately is not the only thing that's going on. And so here we go. Let's dive in a little bit into what some of the drivers are more generally to health insurance pricing, particularly for the patient. So as we've discussed, there's an increased medical and prescription drug spending overall. Drug spending is growing faster than any other medical spending and adding to overall out-of-pocket expenses for patients. These higher expected drug spending is due to higher unit price growth, launches of new expensive therapies, and increased demand from health plans to cover them. Other contributors of rising medical trends include continued inflation and the expanded use of behavioral health services. When it comes to regulatory uncertainty, it's been a year, guys. So due to the regulatory uncertainty, rate filings actually happened for insurance plans way earlier than a lot of these laws and regulations that passed this year were actually finalized. And so because of that, insurance plans had to figure out where did they fit in all of this? What were their margins going to be? And so even now, after these policy changes have been passed, they didn't really understand what enrollment was going to look like, cost, what that risk pool was going to look like under this level of uncertainty. And then moving on, there are a ton of state-based factors on contributing to what out-of-pocket costs look like for patients. This includes premium rate changes, and other out-of-pocket costs vary significantly by where your geographic location is. And that can be based off of state legislative and regulatory requirements by that state, as well as other market conditions, which Medicaid expansion is one of them, state mandated benefits, supplemental premium cost, and cost sharing requirements. And then finally, we're seeing a shift in this market dynamic, right? And so we talked a lot about self-insured plans. A lot of small employers are moving to that because they view it as a cost-saving way rather than, so they don't have to necessarily carry or cover as much as a fully insured plan would typically have to do. All of this to say, we're seeing a significantly less comprehensive coverage, narrower coverage options across all markets. So not just the private insurance that through your employer, but also in ACA plans, also in non-compliant plans, also in Medicaid, also in Medicare. So what are some of the prior to this year, what were some of the health insurance policy trends for regulators? We talked a lot about PBM and addressing those problematic practices. That is something that both states and federal government have been really interested in trying to address. Unfortunately, we haven't seen a ton get across the finish line, but that is something of high interest to everybody. Consumer cost sharing, we talked about the accumulator bans and the out-of-pocket caps, particularly for insulin, but the accumulator bans, and you can see in this map, 25 states, District of Columbia, have already banned accumulator programs, but that's such a limited scope in what that actually can accomplish, right? Because they're only for state-regulated plans, which is maybe a third of the population at most. Improving the prior authorization process, again, an extremely bipartisan policy, but it can be done in a number of ways. Excuse me. And because of that, and there are only so many levers that states can do, the federal government prior to this year has been very interested in this, particularly in the Medicare market, and looking to see how they can streamline that process and use data that already exists. Oh, excuse me. And then, as Emma was talking about, there's not a lot of transparency throughout the supply chain, and that's been another heightened issue, not just in drug supply, but throughout the whole system. Excuse me. Yeah, that was, oh my gosh, thank you so much. Thank you. Such service. Thank you so much. And then something that we've seen overall is really, what is this role of technology? I think that this isn't just specific to the healthcare system, but it's really the broader topic that everybody is trying to figure out, where does AI fit? Where can we streamline these processes in automation? And regulators are trying to figure that as well. Now, regulators, unfortunately, do not operate in a vacuum. We do have the insurance companies doing their own things as well, including what's listed here of consolidation and vertical integration. Emma mentioned that 3 major PBMs essentially run the whole market. Well, those PBMs also are part of insurance companies, and those then own specialty pharmacies, which then also have a special relationship with some providers. And so because of that vertical integration, it may be a black box for us and the federal government, but it is not for the insurance company. It is not for the PBM in the same way that we would view it as a black box. So we're seeing more and more and more of this, and that is directly impacting how patients can access their medications and other services. Something else that my colleagues talked about is these third-party contracting. It's accumulators, maximizers, alternative funding programs are of extreme concern to me as well. I'm glad that you brought up the international importation because it is horrifying. But there are also a number of other things that they're trying to do, and they are constantly evolving, and it's incredibly hard to pin them down. Something that we're seeing more and more are these alternative financing arrangements. That means if you're looking at a list of health plans, you're going to see an increase in high deductible health plans with health savings accounts. There's a lot of interest in that because that makes the insurer and sometimes regulators feel like the responsibility is on the patient to make those decisions for themselves. But there's a lot of loopholes with those types of plans. And so that really can impact how a patient can access their medications. The other option is through ICHRAs, which is a new development, which it's the individual choice health insurance, health reimbursement arrangement, which is looking at employers, particularly small employers. They don't want to necessarily run their self-funded plan. They're looking to the marketplace and saying, hey, we'll give you X amount of dollars, you just go and take care of this yourself. I don't want the responsibility of it. So that could be a positive thing that we are looking at long term. Excuse me. Unfortunately, we are also seeing insurers narrow networks, narrow formularies, but then finally they're looking at this increased reliance on technology. We know that they are using AI as part of the prior authorization process. We know that they are looking at new ways to use and incorporate AI, and what does that mean ultimately for patient access through the denial of claims and everything like that. So that's just the landscape. Let's talk about what happened this year. So there's been a few congressional changes. Over the summer, the 2025 reconciliation bill was passed. This is going to result in limiting funding for states for their Medicaid program, implementing work reporting requirements and more frequent eligibility checks for some individuals on Medicaid, increased cost sharing for some individuals on Medicaid, decrease in retroactive coverage. There's an HSA change in there as well, which allows all bronze plans to be considered HSA high deductible health plans. I bring this up because, again, there's a lot of loopholes that are associated with HSA plans, so it's something to be really, really careful when you're evaluating that for your patient. And then finally, we're in a government shutdown, and one of the arguments is around the no extension of the enhanced premium tax credits. This has been a fight that we were anticipating for almost 2 years now, and unfortunately has yet to be resolved. So these changes are going to exacerbate trends that we were already seeing, meaning less money for Medicaid programs, more coverage loss, and increased access issues. There's also been a lot of executive action. So this year we had this marketplace integrity rule, which significantly makes changes to the ACA marketplaces, as well as has broader impact for employer plans as well. There's a non-enforcement of short-term limited duration rule. The previous administration made it really hard for patients to enroll and stay enrolled in these non-compliant, very much intended to be short-term plans. They are no longer enforcing that rule, making it more likely for brokers and agents to go after patients for non-comprehensive insurance options. There's an expansion of catastrophic coverage, which again was originally passed in the ACA for a very, very narrow individual group. Individuals who were under 30, very healthy, didn't have a lot of expenses, but needed that insurance coverage. This administration's response to the lack of expansion or continuation of enhanced premium tax credits is to expand this catastrophic coverage to more populations, but it is not the same as getting a full plan with full benefits. It is the only thing that they're looking at is cost there. And then there's a number of executive orders that have happened related to cost of prescription drugs. This will likely not have an impact on people with CF, and there's or really the drug system overall. So most of these actions will lead to the destabilizing of the private insurance marketplace, leading to restrictive benefits, increased out-of-pocket contributions, and underinsured patients with less comprehensive coverage. Now all these federal changes aren't happening tomorrow. They didn't happen today. There's going to be a long lead time for this. So we're going to see some of this happen this year with the Medicaid stream already, funding already stopping. Again, with the expiration of these premiums, enhanced premiums. Work requirements are going to start trickling in next year. We're going to start seeing marketplace enrollment, stricter enrollment verifications. And then in the next couple of years, we're going to see Medicaid eligibility checks more frequently, reduced retroactive coverage, and additional cost sharing. So that's pretty bleak. Let's talk about what some of the opportunities are. Okay. So I just talked about how this bill was not great, especially for patient access, but there's a lot of work that needs to be done around it, and that implementation is going to take a long time and a lot of work. So there's a real opportunity to help protect people with CF throughout this implementation process from the federal government. Something that was talked about here is that because there's no there's no transparency, there's no oversight. That is something that we have seen interest from in this administration, in previous administrations, to get greater transparency and oversight and accountability throughout the entire healthcare system. And then I do think that there's still an opportunity when it comes to incorporation of technology to decrease costs for both patients and providers. There are a number of things that all of you do on a daily basis that you don't necessarily need to be doing. And if it's done and implemented in a correct way, it can be extremely beneficial for all of you. On the limitations for federal, there's limited opportunities to provide to pass bipartisan legislation. I think that's pretty obvious. There's a regulatory process is stalled right now because of the government shutdown. Most of the people who are not working, unfortunately, are the ones that implement policy. So we are kind of in a waiting period. And then there's also this ongoing dispute over what the scope of executive order authority is. How much can they actually influence with just the president signing a piece of paper? What does that look like long term for implementation? For the states, I go back to the fact that there's a lot of opportunity when it comes to implementing these HR1 changes, particularly when it comes to minimizing Medicaid disenrollment, loss of services, and other harms. It's going to be very difficult because it's going to be different in every state, but there are a lot of chances for us to intervene in that way. There are opportunities when it comes to enforcing consumer protection rules that are already being loosened at the federal level. So, for example, I brought up the short-term limited duration rule. That, while it is not being enforced at the federal level, that doesn't mean states can't enforce it. The rule is still on the books, and states have the flexibility to enforce it themselves. That's just one example. And then there's the developing innovative strategies to improve affordability and expand access. I think there's a lot of really amazing things that are happening in the states. They are also terrified of the cost, and they are looking for all new ways to try and reduce that cost burden for themselves, but also the patient. When it comes to limitations, there's a significant federal dependency on who sets the floor. States don't really have the opportunity to create something new in a way that they would like to. There's also significant budget constraints, limited scale of who they are actually impacting, and then the fragmentation creates more of a patchwork system of regulatory inconsistency across states. So what is our role in all of this? I would not be doing my job as the CFF policy person to talk about what we have done already about advocating for coverage and access this year. It's been a long year. And it's only October. So we have done a ton when it comes to working with other patient groups to talk about what new restrictions will look like to patient access through the Medicaid marketplace. We've relied heavily on the CF community to help inform legislators on how we use Medicaid. It's not necessarily the traditional way that people would assume. We talked about vaccine coverage and advocated that for changes through our payer engagement, and we're really highlighting real world impacts of not just all of these changes that are happening, but some of the PBM reforms that we're hoping to see long term. But we are not alone. We have all of you as well. And so we have a number of resources to help support and inform you. There are QR codes in this. I think they're also in the slides in your app, so you can access those that way. And there are even more resources. My incredible Compass colleagues, we would not be able to do our jobs without them, are always here to help. And then finally, you are the reason why we are able to do all of this. And so please help us get involved, help sign up and be advocates. I think we've had 300 people sign up for advocacy alerts. We'd love to keep that trend going. And so we can always use your voice. And that's it.
That's great. Thank you, Teresa. Next is Kirby Smith there we go, Kirby. Kirby's co-moderator here. She is a pharmacy technician. I absolutely love her title, actually, at the University of Missouri. She's the patient medication liaison. I think we all need patient medication liaisons to help us through this jungle, as we said earlier, this forest that we have to get through. So she'll be talking about the role of social determinants of health in this issue. Kirby.
Thank you, Brian, and fellow panelists. You guys have done an amazing job introducing, tackling insurance issues, PBMs, and the future of our health insurance. So I'd kind of like to shift the conversation now and discuss how we can identify barriers that our patients are facing in order to connect them with resources like Compass and others that are available for them. No disclosures. All right, so we'll talk about what social determinant of health assessment tools are, how we can clinically integrate those into your practices to identify patient needs, and then how to get them connected with resources. We all know Compass. We all probably use Compass more than they'd like us to sometimes, I think, or that they're capable of at all times. But there are other ways to find local resources as well for your patients. So first off, what is a social determinant of health assessment? This is something, it's a tool used by practitioners within the clinic, and it's to identify unmet social needs and barriers for the health. There's a lot of factors that go into that, such as education, financial stability, food insecurities, and there's a lot of sub-factors as well. So it could be varied from somebody that needs assistance with GED completion all the way up to tuition assistance, or fighting air quality or poor housing conditions, or they may have English as a second language. These assessments are standardized and evidence-based, and they're made to support the whole patient. Medicare B does cover one social determinant of health or SDOH assessment every 6 months, and it can be provided during an annual wellness visit or other qualifying visit. And it can also be administered via telehealth. There's the HCPCS codes if you need it, so that you can implement that into your practice. So what are some of the considerations? Yes, these are standardized, but there's various screening tools that are available to you, so finding the one that's right for your patients. So things to consider. Does this assessment adequately assess the barriers that be unique to your patient population? For example, we have a significant Amish population in our southern area, so does it address the uniqueness that they may have with their religious and cultural beliefs within that assessment in order to get down to all the details that we may need to assist them? How is data being collected? Is it something within the EMR? Is it a form that's being sent out? How are you collecting this data with your patients? Are there sufficient questions to pinpoint the specific needs, i.e., does it just ask, I can afford my prescription cost, and leave it at that? Or does it go dive deeper and also address income a bit if they have income? If they have adequate insurance coverage, does the plan I have provide the coverage I need for my disease state? Or do they just need additional assistance via grants or something else where they just have an unaffordable copay? And then once these are identified, are these being tracked in the EMR and the patient's chart? I think this is one thing that I don't see enough of, because I know we have a lot of patients in there, but there are diagnosis codes that are going to be on the next slide that I'll share that actually can be put in so that you can document appropriately what this patient needs assistance with. And then are you doing a note, whether it's the social work that's doing it, the provider, the nurse, wherever it is in the patient's plan, is it being documented within the chart? And then follow up. This is probably one of the most important steps. Did the patient actually get in contact with that resource? Did that resource provide what it said it was going to provide? Was what they provided sufficient enough? Do they still need additional assistance with that resource? These are some examples. They are hyperlinked, so if you have access to the slides, you can actually view the questions to see what is listed there. But as you can see, there's various samples that examples of what that assessment tool could look like. And there's also various ways that those can be integrated into your workflow. The social determinant of health assessment could be part of your health risk assessment. It could be something that you send out to your patients prior to the visit as a pre-clinic form. and then reviewed during your pre-visit planning and noting those issues to be addressed during the visit. It could also be part of the rooming process for your nursing staff. And then again, like I said, make sure that these Z codes are appropriately documented in the charts. And these are just the base categories. There are dots that go behind them that further categorize and specify those needs. So here's where we need to focus on what's needed. As you can see, there are 6 main categories of barriers. These 6 main factors can contribute to up to 80% of patient outcomes. The first 4 that are listed there, economic stability, neighborhood and physical environment, education, and food, account for the majority of those outcomes. Community and social context, as well as healthcare system, still contribute largely, but they're not quite as impactful as the first 4. And it could be something as simple as, say, neighborhood and physical environment, I think is a big one for our patients. If you live in a big city, Seattle, Los Angeles, Chicago, or whatever, where they have a poor air quality just because of the nature of where they're at, how is that affecting them? Would it be more helpful for them to move to the suburbs where the air quality is a little clearer, if they're capable of it anyways? So it's things like that that may not necessarily be immediately obvious, but actually contribute largely to patient health. And then when you're finding the resources, we have to close the gaps. And the gaps are kind of hard to find because everything interlaps so much. For example, I'm at the University of Missouri. We have a pediatric and adult care center in Columbia. We have 2 pediatric and 2 adult care centers in St. Louis. And we have 1 pediatric care center in Kansas City, Missouri, and the adult care center is on the Kansas side in Kansas City, Kansas. So what's been a difficult struggle for many of those patients is if they're on Medicaid, up until recently, the patients that were transitioning from the pediatric center to the adult center, if they had Medicaid, they could no longer be seen at the Kansas care center because Medicaid was not accepted there. So they would have to come all the way to Columbia, which is an additional 2-hour drive. Also, Columbia is almost smack dab in the middle of the state, yet we are still the furthest south in the state as well. We offer an outreach clinic once monthly to our patients that live further south so they don't have to drive quite as far. So that's one thing, that their environmental factor, where they're located, affects their healthcare system. Or they may need to find other resources for economic stability to be able to get a transportation. I know our social worker does a lot of coordinating Medicare rides and Medicaid rides to get patients to their appointments. So resource availability to patients does vary quite significantly based on a number of criteria. The resources that are listed there below, I personally use the findhelp.org. It's a great little app, and you can plug in the zip code for where your patient is at, and then it'll show you dozens of different accessibility that are local to that and available to that area. Some of them may only be available based on veteran status, age, income, if they have a disability, or if they have their family and marital status. So, but it lists those criteria on there. And then there's usually a link that takes you right directly to that source that can get them set up with it. So it's very easy to get them set up with those tools. But again, the responsibility is on us to follow up and ensure that they did get access to those and continue to follow up and that they no longer need those access, because sometimes they can get access and then they have to come back. So it's all about documenting and following up and making sure that we're getting them, having that soft handoff, I like to say, to the resource that they need. So I know that was really fast and really brief, but hopefully you have a little bit of an understanding of what these assessment tools are, how you can integrate them into your clinics and document to focus on what the patient needs are, and then find out what resources that they're truly needing based on how those are interconnected. So. And I think I can leave the questions up there because we've reached the end. If you haven't already done so and you have questions, feel free to put them in the app or come to the mics on either aisle to ask questions, and we'll just dive right into them. Thanks, Billy.
I guess these mics are on you. So one of the questions that just came in for the panel here is, are there any recommendations on classes folks can take, healthcare folks can take, to better understand plan documents and support patients during open enrollment? So rather than necessarily going to Compass, finding ways to do Compass-like work in our own institutions.
I think that was maybe directed at Colleen and Katie.
Yeah.
Just touch it, right?
I think it's on.
So the main thing that's already available, though that is a great suggestion, is the Navigating CF series that is available on cff.org. Navigating CF series was put together by case managers as well as some other folks on our team about really just like health insurance literacy, how to change plans, what to look out for, all of that. So there are some self-help resources there as well for that particular person. If that they can come to, there was a one pager that was just approved by comms just a couple of days ago, and we can get that disseminated to you as well.
And I'll add to that too, as a pharmacy technician, sometimes there's a lot of area where you have the opportunity to bridge that gap from the pharmacy side to the social worker side. And I know CE Impact offers a community health worker course. It's an 18-week online course. You meet once a week, and it gives you a lot of those tools that I discussed about during the social determinant of health screenings and how to identify some of those needs in your patients. So. And yes, we have one at the mic.
Hi, I've got two questions. I think the first one is for Colleen. Is one of the states that is working on Medicare coverage of vitamins is California?
I don't believe so. Olivia, do you have that off the top of your head?
No, but please talk to me afterward.
All right, cool. Because we have a lot of people in California, including me, that are struggling. We have primary health insurance with their dad's job, and then we also have Medi-Cal as a secondary payer, and we can't get our vitamins covered or the probiotics, so we're falling in this weird loop. The second question is about the social determinants of health. Having been divorced as a parent with kids with CF, and I know the divorce rate is a little higher in people with CF and their families. Has divorce been added to the questionnaire when we're determining the social determinants of health?
I'm sorry, can you repeat that?
So because the divorce rate is higher and people have CF in their families, and I'm a mother that got divorced 15 years ago, remarried, but I know it's more common, and I know that in those situations, there's less resources, there's people skipping treatments, there's a lot of issues going on, missed medications. Has divorce been added to any of those questionnaires when we're looking at SDOH?
I would have to look specifically at each tool to see.
It's not?
I heard a no.
It's not embedded into the Epic tools, which is probably, Epic has standard formats that they use, and they use a standard questionnaire, so I was like 7%. It's not in there.
Okay. And so for those, just so it's on the recording, the response was that, no, you're fine. So the response is that the divorce is not embedded into the form that is in Epic, which is many of our centers, as one of the questions for the social determinants of health.
Is there a way it can be added? I've been trying to push this for years, and I just feel it's such an important measure and dictates so many things, insurance coverage and everything else. I'm just curious.
My center doesn't work with Epic, so I don't have an answer for that, unfortunately.
You can submit a ticket through your ISD, and they can build you questionnaires based on your parameters that you would like them to, because I've done that.
Okay, I'm a mom, so I don't work in the clinic, but it's been such a thing for me that I want that to be included in the data, because I do feel that it does impact people's health.
Yes, 100% it does.
Whoever's here from the foundation.
Yes.
you start
For
thinking.
those of you that are in Epic, you can reach out to the ISD and ask for that form to be added, to get that question added into your SDOH.
And also, just to as an aside, that does come up with Compass as well. That is something that we collect there, as well as just like you said, it is very important to know and dictates a lot. So yes.
I have two questions as well. The first is regarding self-funded plans. Is there a way to kind of predict? I mean, are there more? Is there a certain type of industry or company that would use that type of plan? I mean, are they typically smaller? Are these the, mom and pop kind of places that use this? Or is there any way to kind of ask, if someone calls me and says, what do I choose? And if I even can ask them if they think they have that plan, do sometimes companies offer both, no, so you're self-funded or you're not. So, okay. Mm-hmm. But I guess, I'm just trying to identify in advance maybe who those patients might be that may have a problem. Anybody?
No, go ahead.
So it's going to be a mix there. So a lot of large companies are self-funded, so the very large companies, but also there's a lot of much smaller companies that are self-funded plans, and they oftentimes will have secondary insurance on top of that. So it's called stop-loss insurance. So if they do have like a high-cost event that wasn't predictable, they have additional coverage. So it's insurance on insurance. So the short answer to this is it's not one type of firm. And I think it is shifting more over time. And I would be curious if you found the same thing, because a lot of these companies are really trying to control costs. And by self-insuring, they can take some of that risk in-house and choose what to cover in a different way. It gives them more control. And so we have sort of seen that shift as costs have risen.
So go ahead.
Oh, no, the only thing that I would add is that you're asking if when they are in a new job, how do they determine whether it's self-funded or if they're the only way to really determine that is through the summary of benefits. And that is something that you wouldn't really get until you are already deep in the process, if you haven't already started.
So, which makes me kind of wonder, when you guys are advising them, because I find that insurance is super, opaque until you actually get it. You have to decide what you want. And then you're like, oh, look, they don't cover this. And how do you figure all that out previously do you have that information when you're helping them?
Yeah, so I can speak I've definitely gotten calls where people already know up front, they're reaching out to us and they say, I already looked into this and found out it is self-funded. What do I do? Or they don't know, and then they give us the documents and basically a lot of people will even say, I'm trying to decide if I'm going to accept this job offer, and the self-funded worry is kind of keeping me from knowing what to do here. It gets tricky for us because we can't necessarily say, oh, stay away. We can't tell them what to do. But what we can do is, do a little bit more, since self-funded plans are all so different. We will still do a deep dive in the documents and kind of see what the big picture of it looks like. And then if we do see any big red flags, then we will tell that person, okay, well, here's another direction that we can look at, which could, for example, potentially be on the marketplace. I know that sometimes, it gets a slippery slope because we don't want to tell people, hey, don't sign up with your employer, go through the Affordable Care Act. But if it looks like that, maybe, especially if that self-funded plan won't even cover their doctors or medications, it just looks bad. We try to tell them that in a more, not so, this is horrible, but, so we'll say, okay, well, sometimes people consider, opting out of that employer coverage. Let me take a look at what's available on the marketplace. I do want to let you know up front that if you were to go in the direction of marketplace, you wouldn't qualify for that premium tax credit because you do have employer coverage available, but this is a direction you can go. So I will take a look to compare both. And then again, kind of pointing out those similarities and differences, and then really just, giving them all that information for them to decide okay, do I want to take this job and just go with the self-funded because it's looking like the costs might not be so bad compared to, so it really just depends. But again, we can look at all of their options and give them the big picture of what things are looking like.
So does a non-self-funded plan, fully funded, I guess, do those companies, like say my employer, the hospital, do they get to pick and choose what they cover, or is it just part of like, here we have, Cigna or Blue Cross Blue Shield? Do you have the same coverage as everybody else who has Blue Cross Blue Shield? Is it really only the self-funded plans that kind of pick and choose, or do?
Yeah, so it's a weird dynamic. They're with fully insured plans. What they do is they take a standard plan that the insurance company offers. So we'll use Cigna as the example, right? There's a standard plan that they can just say, okay, we're going to input X amount of money and we're going to have the plan take care of everything for us. And that's essential health benefits, including standard visits, prescription drugs, and that there's no real changing what's in there. You can add certain drugs to the formulary if that's what that particular employer wants to do, but that's not necessarily how all of them do. They're doing this as an ease option. They might cost them more long term, but they really just want to offload it. When it comes to self-funded, Cigna is still a third-party administrator to that, so it can still look like a Cigna plan, but because of the financial arrangement that they have with the employer, it looks different. So when you're actually diving into the benefits, and there are significantly less patient protections when it comes to those types of plans because of the flexibilities that are allowed.
Hi, Jeff Cole from OHSU. So a statement and a question. So I'm one of the Associate Chief Health Information Officers. I also run our data equity core for the university. So SDOH data is really, really important to collect. I agree with you completely. I will caution about creating separate forms for individual patient populations because that data needs to be harmonized at the institutional level. Most places don't have the IT resources to do that. And then what happens is, and we've seen this with some pockets at our own institution, is, for example, a patient with CF, we have our own data. If you have their own data collection forms, they get admitted to the hospital. The SDOH reporting now doesn't pull from those data fields because they're not using the standard fields that the institution does. It also limits the ability to generalize data through things like Cosmos, where we're going to have all this data aggregated across the United States to do some better power. So there is a balance there, and I just want to highlight that balance because we have to sometimes get 80% of the way there to get a 100% sustainable solution. My question is, and I can't remember which one of y'all said it, so I'm sorry. We're talking about technology to reduce costs, which I think is going to be interesting because the insurance companies are using technology to increase costs at the same time because it's going to be dueling AIs. It's going to be like Skynet. Yeah. Right, going against the Matrix, and they're going to fight over prior auths. But we're not exactly sure who's going to win, but most likely the patients will lose. The thing, though, is if you look at our center reports that come out every year, it's very clear that there's wide variance in resource utilization and allocation. And I think that one of the main ways that we can reduce costs is by actually working as a society, meaning a CF society, to really start coming up with best practices and recognizing overutilization. So Elliot Dazenbrook had a great article a decade ago now that looked at inhaled antibiotic use in patients with and without Pseudomonas. There is something like 8% of patients with FEV1s over 100 not growing Pseudomonas were on 2 inhaled antibiotics, right? So we have to take some responsibility in what we do as well, both as a foundation, as a society, because especially in highly effective modulator therapy area, we have to start looking at some de-adoption when appropriate. We have to work on guidelines. There was just in the 2024 report, I think there was 10 centers with a median hospital stay over 14 days in spite of stop 2. This was adults, I don't do peds. So I just want to sort of say, where is the foundation in supporting that and doing that research, that choosing wisely research and taking that responsibility? Because otherwise, if we leave it up to the insurance companies, the patients, again, are going to suffer.
Yeah, I mean, you bring up a great point because of the way that CF care has just so much evolved, particularly in the last 5 years. I think that that's definitely conversations that are being had internally. I can't speak to particular what the care model will look like in the next however many years, but that push and pull between what insurance coverage really looks like and what care looks like and the necessity of care and that best practice is definitely something that's under consideration.
Yeah, and I think it's just the finances has to be put into the matrix.
Yeah.
Wrong matrix term, sorry, everyone. But it has to be put into the model, and that financial component cannot necessarily be determined by what insurance will or will not pay for. It has to be based on what we are as stewards of the system. And we have to start acting as stewards of the system financially, as opposed to advocates to get financial resources, which is important, but it's only one domain.
Absolutely.
I'm gonna give a question from the audience that this is, Emma, for you, and I kind of like the way it's worded, so I just want to read it. Do we know if anyone consistently tracks the rebates that have been stolen by PBMs from Medicaid and state health plans? And the word stolen was in the question, not mine. That came in.
Short answer is no.
Okay.
I know that they are doing a lot at the federal level to try to have a better understanding of these rebates. And in fact, there was legislation passed, so they are starting to now collect data. I will say, you mentioned the vertical integration piece. Now the insurers own the PBMs and they also contract our own pharmacies. And so some of those rebates may be taking different forms now. There might be fees in addition to rebates. And I think the ability to track that depends on the ability to monitor that. And that's not there yet, I don't think, even at the federal level. So short answer is no. And I'm sorry to be more disappointing, at least to my knowledge. Yeah.
Thank you. I just want to thank you all for taking the time to address such a complex set of issues that I know we all deal with every day. I was just wondering, I know all of us were trying to take pictures of the slides very quickly, and because they're so helpful, because all of these terms just make your head spin and trying to figure it out. It's so complicated. I don't know if is there a way to create like a set of cheat sheets or something like based on the slides, just I don't know, just so we can kind of have reference for ourselves and also when patients come into our office and, have questions, it'd be so nice just to have not, all of those slides, but some of those slides in a more condensed version. Just a thought.
So I'm going to start.
Yeah,
and then you can
yeah.
It sure does. So it's not going to be exactly what the slides are, but we have a ton of resources that are available at my.cff.org in our resource library. So that's part one. Part two is we have similar to Colleen being fresh off the presses with their one-pager. We also have a one-pager with the specific changes that are happening and what that implementation looks like for both Medicaid and Marketplace. And that's a one-pager that should be available on that. It is, and it's in the app. See, Kim knows. Kim is our resource expert right now. And then for Compass specifically, if there's anything you want to add. No.
Thank you.
Great. Yeah.
Hello. I think this one's for Teresa. For those of us who live in states that I don't believe have put in the bans on copay accumulators, because I think trying to chip away at this one aspect at a time. Other states that have been successful in doing that, have they been able to do it as like a complete ban? And also what kind of factors help tip the scales? And I'm thinking of this from the point of advocacy. If I have the ear of some legislator, what really helped those states get to that goal?
I would start off with education on what these programs are, which is what we do both at the federal and at the state level. I'm so curious what state you're from.
I know Brian. New Hampshire.
Okay, perfect. And we have one of our state's policy specialists in the audience who would be happy to help you with specific tactics to help influence what legislation would look like at the state level. It's a patchwork system, but at least they are addressing some plans in those states.
I'm sorry. I have so many questions, but I have something specific to my state or my hospital where I'm in Texas, and our hospital recently started this thing called a facility charge. Yeah. And so what's happening is our patients are getting billed $200, $300, just this random charge after their appointments. And they're calling us and saying, what is this facility charge? I've never had this before. Why do I have to pay this? And so I tried to do a little investigating because, of course, our managers are all like, oh, just tell them they can pay it $5 a week or I'm like, no, why? This doesn't make any sense. And especially to me, my understanding of, when you have insurance, commercial insurance, that you have a copay, that is the contracted rate between the hospital and the insurance company, and that you are not responsible for anything above and beyond that other than maybe, if you had labs or an x-ray or whatnot. But for the actual visit, that is not your responsibility. So getting this bill, I would be alarmed if I got it. And so, they basically told me that Medicaid pays it and that they're not allowed to bill something to one group of patients and not everybody. And that, they don't have to really pay that. Because, no one, I don't know the rule or the law, but that I guess you're not responsible. You can't be sued or you can't be sent to jail or whatever for medical debt. And I thought, well, who wants to be put on a list for, people coming after you for your money, So anyway, I am extraordinarily alarmed about it. And I don't know what to tell the patients. I tell them, and we have had people leave, because they don't want to pay $200 every time they come for an appointment, or they just want to do telemed because, they don't have to come in. So I don't know. Anybody? I don't see how they can get away with that. Or am I wrong with I think it's just mean. Or is it illegal or is it just mean? Greedy. I'm sorry. That's on tape, isn't it? Sorry.
Oh, no, the site of care. I assume that's the site of care thing. Yeah. Right? This is actually pretty common. This is a facility fee associated with a hospital or hospital outpatient department. Would be interested to hear more about. There is actually some pending legislation about site of care. At least it's been discussed a lot. So this is a site of care thing. It increases costs. We also pay hospital-based facilities more. Even if you think about a lot of hospital outpatient departments are like an office in a strip mall. They're not like a hospital in the sense. But that's where that's coming from. It's a common issue. It hits patients all over, not just in Texas. And would be very interested in your...
Yeah, so that's the basis of why they're getting the bill, to talk about their concerns around medical debt and potentially the dispute resolution over who has to pay this bill. There was a law passed, I want to say 3-4 years ago now, the No Surprises Act, which has still very much been struggling to be implemented because it's so complicated, but it does have something to do. There is a component to it where if a patient is getting this type of bill that was not part of their insurance structure, they should not have to pay for that bill. There's been a lot of hiccups with how that's being implemented, because then who is paying for that? Is it the provider? Is it the hospital? Is it the insurance company? So my response to individual cases around that is to go directly to the hospital, which it sounds like they're coming to you, but you do not handle the finances. So I would go directly to finance on that, help with the independent dispute resolution.
I just want to put in a quick plug for my friend in New Hampshire. I think asked a little bit about advocacy. And so as Teresa mentioned, I'm a state policy specialist. And so if you ever want to get involved in advocacy in the states, feel free to come talk to me. Also, just want to emphasize the importance of advocacy in making these bans happen, particularly telling patient stories. I think is, to answer your question that you had, is I think what really puts these bans over the edge is those patient stories, the real patient impact of how these accumulators are really hurting these patients. And so that's such an important piece, I think, of the advocacy. Yeah.
I would personally love to connect with you after this.
I was just going to add, just so that everybody's also aware, we're starting to see fees for the time of day your patient comes for their appointment. So at our institution, if you come before 8 a.m., you are charged an undisclosed amount of dollars, and it varies because unfortunately my husband got the bill from my own institution, and I was like, what is this? They did not tell him when he signed up. They did not tell him when he checked in. It was listed on the wall as the disclaimer. So just keep that in mind, that if you're starting to see those charges happening for facility, you might also start seeing charges for time of day service.
That's horrifying.
Insane. That one I haven't heard before.
Yeah, I haven't heard that. So thank you for bringing that up because I haven't heard that.
Can I just add something? I didn't realize this was going to come up. So nearly 3 years ago, they moved our clinic from the outpatient building that was part of the medical school to inside the hospital into a hospital-based clinic, and of course never told us that our patients would end up with insane bills. As the social worker, I think I've been begging someone to help me with this for nearly 3 years, and I keep being told stupid things like, well, they should apply for charity care to cover that, or some nonsense. I've tried to kind of deduce what the issues are, but it's also very hard because the bills are really hard for patients to understand, and they're even harder for them to get them out of the My Chart and send them to me in any detail. I now finally have a finance person's ear that I'm working on, and ultimately what the CF group is asking for is that the reason we moved was so that they could profit from they could use 340B money, right? And so we're basically now saying to them, hey, we moved, use that money to defray the costs and don't balance bill patients, because we do know that there is an amyloid clinic that moved to a hospital building and made that agreement ahead of time because their drugs are $700,000 a year, not $300,000 a year. And so the hospital is making a ton of money on his 340B patients, and his agreement with them has been, you will not balance bill my patients. But what I did learn, at least, and I don't know exactly what to do with it, was that for some of the patients that were getting these balance bills of up to like $700 for this clinic visit, now that we moved to a hospital, suddenly their PFTs are very expensive where they didn't used to be. Yeah. And because they're getting charged a facility fee for those. But in addition, that their clinic visit is being now treated by some insurances, and the hospital sort of blames the insurance plan, by some insurances as a hospital outpatient other rather than an outpatient visit. Yeah. And so then that in some plans becomes subject to deductibles and co-insurance, which can be up to like 50%. And I am like feeling rather desperate in our place. And yeah, obviously I'm glad to know this is a national problem about what this trend is going to look like, what it is now and how it's going to unfold. And I guess if there's any legislation that might come to stop hospitals from being able to do this, really.
Yeah. So we did not really talk about the hospital component to all of this today. We really focused in on the role of insurance companies and their subsidiaries and PBMs and all of that fun stuff. There's definitely interest in the transparency around facility fees, what that looks like but I would just like to reiterate that while there is interest, it's really hard to pass legislation right now. And so while this is definitely a topic that's being discussed, I don't see it being resolved anytime soon. If at best, maybe next year, but I'm not hopeful.
What hospital are you at? Did you say?
Rutgers. We are under the umbrella of the Robert Wood Johnson Barnum system. Oh. And that's changed a lot of the financial situation for us.
This has been great. We unfortunately, I think, are at time. I know a lot of people have been moving on. But I think if there's other questions you guys have, the panelists are likely to be able to stay a few more minutes anyway. I know some of us do have other things we need to get to, but thank you so much, panelists. This has been wonderful discussion, and audience, great questions. So thank you.